Okay, and share my screen. Okay. And as always, my computer is moving slow as molasses. All right. So today we are beginning our exploration of our clinical ethics textbook. This text is designed to move us from the foundational principles into the actual practice of clinical ethics. So it will move us from those principles into actual bedside cases and bedside decision making. It moves us from theory into the realities of treatment. And they accomplished this by introducing the four-box method, or the four-box model. This is extremely common practice across clinical ethics. If you are ever on a clinical ethics committee for a hospital or any clinic, you are likely going to use this method. So up to this point, we've been primarily working with the principles, autonomy, beneficence, non-maleficence, and justice, but this framework is designed to give us a moral orientation in the treatment room. It doesn't always tell us how to structure a clinical conversation in real time, but it does provide a solid guideline for how to approach ethical dilemmas in the treatment room. So our authors, Albert R. Johnson, Mark Siegler, and William J. Winslade, are providing a method to collect, sort, and organize all of the facts and opinions that exist within real cases. Their approach is really infused with the principles from Beauchamp and Childress, but they are really open to other ethical dimensions that can shape the therapeutic relationship. So some of the ones that they mention are integrity, compassion, empathy, and fidelity. So their method really asks, how do we systematically analyze a case in a way that prevents moral blind spots, in a way that organizes the facts of the case before values are brought into the picture, in a way that keeps the patient at the center of our decision making, and avoids that issue of moral drift that we discussed specifically with the Willowbrook School case. So this is about practical decision making. It is a model designed specifically for a clinical ethicist, but in the introduction to the text, they also invite anyone working in healthcare to engage with these ideas because they are extremely useful. So the four-box method introduces medical indications, patient preferences, quality of life, and contextual features as the four primary dimensions of an ethical problem. So the four domains here really flow from the four principles that we saw from Beauchamp and Childress, but it prioritizes things according to order. So the operations or the order in which you do these things, the order of operations, is really important here. So we begin with medical indications because without clinical clarity, ethical analysis is just kind of floating on feelings, right? Without a correlation to what is real or what might be possible in a real case. So medical indications are the diagnostic and therapeutic interventions that are being used to evaluate and treat the medical problem of a case. Patient preferences come next. They express the choices of the patient about their treatment or the decisions of those who are authorized to speak for the patient, such as a designated surrogate. So preferences have the potential to further restrict the methods that are being used in treatment. So though it preserves autonomy, it also serves a clinical role in investigating and reporting patient preferences in order to further reflect on medical indications. Quality of life is the third domain. It documents a patient's degree of satisfaction, pleasure, From a utilitarian sense, you could also say the good of a case or the good of a person's experience, and well-being. And then at the opposite end, also, it signifies the degree of distress or malfunction that people may be experiencing in their life prior to and following treatments. We want that comparative analysis. And then, sorry, I'm getting a package delivered. Contextual features come last, and those are the social, institutional, and financial and legal settings that influence potential medical decisions. So you aren't going to talk about malpractice laws unless those malpractice laws have a direct influence on the decisions being made in that case. So contextual features need to remain relevant. You are not intended to explain the entire landscape that this patient exists in, right? We want to pick out the important facts. And on that topic, I wanted to include a case study to kind of give you guys a deeper look at actual Arkansas law. So here in 2023, we saw the passing of Arkansas Senate Bill 199, which targeted malpractice reform specifically for gender-affirming care in minors. So this extended the statute of limitations so that people who regretted certain procedures could file lawsuits against their doctor for an extended period as compared to other treatments. And it applied selectively to those cases rather than uniformly across medical practice. The procedures that they were claiming to have an issue with and to be targeting already required long-term documentation and mental health evaluation and a demonstrated stability of need within those patients. And there were absolutely no gender reassignment surgeries being performed on minors in the state of Arkansas anyway. So they were sort of regulating an issue that didn't even exist. And what are my notes on this? Okay, so an issue here is that this increased the burden on physicians rather than targeting a specific demographic, which was the goal, right? It was to restrict access to these types of treatment because our government has certain values that it is encoding into law, right? But the ethical issue of this case is not only the restriction of autonomous decision-making for patients, it's also the fact that the burden is being put on doctors to bear the punishment from these issues, right? So if we reflect on this law specifically and its contextual features, what or when law selectively increases liability for one form of treatment without providing evidenced justification, which principle from Beauchamp and Childress is being most compromised? Can you all see that discussion question, or is the camera panel in the way? There we go. So what principles might be violated or compromised by this kind of law?
I would say maybe justice and to a degree autonomy, but specifically justice.
Justice, yeah. So selective legal burden being applied to one patient population and one type of care really needs to have a justified foundation in order to not create structural injustice. Yeah, very good. So though the topic of gender affirming care may be controversial and you guys may have your own personal opinions on that, this example is not about taking a political stance, right? we're talking about analyzing how structural forces interact with core bioethical principles. So the law extends malpractice liability in a way that specifically applies to one category of care, unlike general malpractice reform laws, which apply uniformly, right? So this is a targeted thing, which makes it ethically relevant. So from an autonomy standpoint, yes, if clinicians are withdrawing from offering care due to the elevated legal risk, patient choice becomes practically limited, even if not formally prohibited, right? So there was a House bill that specifically targeted this trans youth population, and that one was struck down as unconstitutional. So then they wrote this to take its place. And so that disenfranchises patients and their autonomy, despite not explicitly restricting access to that care. From a beneficence standpoint, physicians may be deterred from providing interventions that major medical organizations recognize as medically necessary. So there is quite a broad history of research as far as the positive benefits of these kinds of treatments. And it is a violation of beneficence of upholding our requirement to care if we are taking these possible treatments off the table. From a non-maleficent standpoint, delayed or foregone treatment can actually increase the risk of psychological or physiological harm for these patients. And then from a justice perspective, the law raises questions about equal treatment under malpractice law and standards. And if one category carries 15 years of exposure while the other only carries 2, we must ask whether that distribution of legal risk is ethically neutral. Why are we allowing this one population to have 18 years to be able to go back and sue their doctor when we don't do that for any other category, despite there being a significantly higher rate of regret for things like a knee replacement surgery? Uh, and then there's also a secondary justice concern here. So puberty blockers, which can be considered gender affirming care, are used in other pediatric contexts. So for patients who have significantly impaired, disabled children, they will use puberty blockers in order to keep their children smaller in stature. And this is so that they can keep them in the home into adulthood, maintain family integrity, maintain home care environments, and keep this individual that belongs to their family in their home. So making a broad malpractice suit against these types of treatments risks impacting other types of patients as well from being able to access those treatments. So again, the goal here is not to argue about the policy itself, but the goal is to show that contextual features, law, regulation, and liability structures can contribute and create ethical tensions when, or even when, the medical facts of the case and patient preferences remain unchanged, right? So we begin with medical indications of what is actually real and what is actually possible. And then we move into patient preferences for how we shape what is possible. We look to the quality of life measurements to view the risk to burden ratios. And then we move into the contextual features to ensure that justice and legal restrictions are being honored as much as possible, right? Were you guys aware of this law? I'm curious if you have any thoughts on it.
I mean, it seems pretty par for the course for Arkansas politics, so that's
Yeah. Yeah, there's always a tension between public health consultants and actual regulators because oftentimes our medical evidence and what we know to be true in the treatment room doesn't actually make it translated into what becomes law, right? Because issues become politicized, The treatment room becomes open. We no longer necessarily honor the sanctity of the doctor-patient relationship, and people try to influence what sorts of decisions can be made within that space. So there's always a little bit of an ethical tension. And generally, I'll be honest, in all of my years of education in bioethics, I think I have maybe encountered one conservative person in my classes. It tends to be an empathetic, right, mutually supportive field that people want to go into, which supports a certain type of personality. So it's a really interesting tension that gets built, right, between people trying to preserve access to care and people trying to recognize certain types of care as inappropriate. So yeah, that's going to be a constant tension, especially in Arkansas. So with clinical ethics, we're looking at a few key differences from moral philosophy, right? So the authors emphasize what's called casuistry, and that is the resolving of moral problems by the application of theoretical rules. So it's our shifting from rules and regulations into how do we actually enact these things. Clinical ethics is very different from constructing an ethical framework, and it more closely mirrors clinical decision making and clinical reasoning. So it asks, what kind of case is this? What features of the case actually matter? How have similar cases been resolved? So clinical ethics is very pragmatic. It's all about what is practical and useful. It is theory informed, but it's very decision focused. So clinical ethics and the method provided in this book is intended to guide practice. Uh, so how do they kind of accomplish this? The goal of their method here is not to eliminate disagreement, but to figure out how to structure it in a way that's useful. So often ethical conflict arises because facts are unclear, prognosis can be exaggerated or misunderstood, patient values become assumed, especially if you already feel that you have certain things in common with the patient, it becomes easier to make assumptions. And it also comes from institutional pressures being unspoken or unwitnessed by the patient and how those may influence the ethical decisions. So the four-box model really forces us to slow down. Clinical ethics is disciplined moral reflection. It's not about meeting a checklist for principles. So how do we accomplish this? We do this through balancing, examining our sources of disagreement, removing idealistic expectations from our resolutions, and comparing situations to paradigmatic cases. So we take a paradigm of a case, something that's well known that has similar features, and we go through reason by analogy. So they talk about weighing and balancing a lot, just like they do in Beauchamp and Childress. The authors explicitly reference Rawls and the concept of reflective equilibrium, as well as principlism. So our authors kind of distinguish themselves from the other two, from Rawls and Beauchamp and Childress. They're not constructing some grand philosophical equilibrium. They are viewing clinical medicine as something that is messy, and so all that they aim for is a workable balance between medical facts and philosophical theory, right? So we've seen this term balance and balancing a lot from Beauchamp and Childress as well. This idea echoes back to John Rawls and his concept of reflective equilibrium, which was initially developed in his very pivotal A Theory of Justice. It is still one of the most broadly read books on the topic of justice. And reflective equilibrium is a method of moral reasoning. It seeks coherence between our moral judgments about particular cases and the general principles that guide how we make those considerations. So rather than rigidly applying fixed rules, we move back and forth between principles, our intuitions, and background assumptions. So we revise each as needed until they align in a stable and reasoned balance. The goal is not deduction from a single master principle, but it's all about coherence. So in clinical ethics, this approach mirrors the process of weighing principles and facts together to reach the most reasonable conclusion in a given case. So balancing is really necessary because, as we discussed with Beauchamp and Childress, no principle has weight in itself, right? Principles don't carry a fixed intrinsic weight, they don't apply themselves. So a principle gains weight in application. Context is what determines the moral force of a principle. So the authors reject the idea that principles are ranked abstractly. No principle always wins in healthcare. Beneficence might dominate when an effective treatment exists, but when a cure is impossible, beneficence weight shifts, right, toward comfort, toward quality of life. So the weight of a principle is always going to be case dependent. And this is a really powerful corrective to the rigid approach to principlism that we've read so far. And principlism can't be effective on its own in ethical disagreements if we aren't giving weight to the current context. So I think that's a really smart shift that our authors make. Some of these sources of ethical disagreement are communication failures, conflicting providers. People want to seek a second opinion, and now they're getting told something different than what they learned from the first doctor. Impaired decisional capacity, changes to the actual patient situation, distrust, whether it be historically seated or in current contexts of mistreatment, and then divergent values. Sometimes it's really difficult for a white Christian doctor to figure out how to best serve a Native American who's lived their entire life on a reservation and has only been brought into a hospital for the first time in their life due to an emergency. So those divergent values can also create a source of disagreement. So this checklist, I think, is really important. It's hidden in a really ordinary paragraph on page 6, but it's so useful because not all ethical conflicts are philosophical. There are breakdowns in communication, breakdowns in trust, breakdowns in capacity that before we invoke grand principles, clinicians really need to ask these basic diagnostic questions. Am I failing to communicate something accurately? Am I really disagreeing with this other provider, or have they made some good points that I need to incorporate into my assessment? So ethical mediation often begins with clarifying misunderstandings. And then that ultimately leads to a resolution, which in the case of a clinical ethics consultation is going to be in the form of a recommendation, right? And a recommendation is not a demanded outcome. It is simply this, based on all the information and my knowledge of the moral principles involved, this is the best likely outcome or option, right? So this resolution emerges from assessing facts in relation to principles, not just the facts alone, not just the principles alone. So this is the operational definition of clinical ethical reasoning. It integrates clinical reality with the normative moral structure provided by principles. So this is achieved through primarily, for this book, reasoning by analogy. So reasoning by analogy uses paradigm cases in order to assess current situations. So this is casuistry in action. Paradigm cases are not strict precedents. They are moral reference points. So they help clinicians ask, how have we reasoned through similar cases in similar situations before? But the authors are very clear here. No case is identical, right? So paradigm comparisons are intended to guide our assessment, but they do not determine our judgment of the case. And Um, that's pretty much all of the introduction, but before we move into medical indications, I did want to go ahead and introduce the four paradigm cases that they use throughout the text, because the more familiar you are with these, the less rereading you're going to have to do as you work through each of these four domains. So case one is called Mr. Cure. Mr. Cure is 24 years old. He has bacterial meningitis. There is a high probability of success with simple antibiotics. He has a clear diagnosis, a clear treatment path, and the key medical indication questions for this case are about what is the diagnosis, what are the probabilities of success, what are the consequences of non-treatment, and are there reasonable alternatives? So Mr. Cure represents the clearest case of curative medicine. He's young, he is otherwise healthy, he has a high probability of success, he has a clear intervention, and he understands severe consequences if untreated. So at this stage, beneficence and non-maleficence strongly support treatment. Later in the book, he will refuse therapy. So that refusal introduces autonomy and transforms what would normally be a non-controversial case into a clinical ethics problem. So this case shows how ethics often emerges not from medical uncertainty, but from patient choice. Cases 2 and 3 focus on chronic disease and progressive decline. With case 2, we have Miss Cope, and I love these names. It's like the board game Clue. So Miss Cope is 42 years old. She was diagnosed 24 years ago with type 1 diabetes. She has a good adherence to medical treatment protocols, and she has emerging complications of microvascular damage. Mr. Care has advanced multiple sclerosis. He is 55 years old. He was diagnosed 15 years ago. He is in progressive decline. He is experiencing severe depression, and that is perhaps affecting his ability to adhere to the medical treatment protocol. And in his case, palliative care is being suggested. So the themes introduced in these two cases are chronic illness, gradual deterioration, and a shifting in the goals of care. So these cases move us away from dramatic cure scenarios and into chronic management and how we handle declining health. So Ms. Cope illustrates ongoing management with accumulating complications. Mr. Care introduces deterioration, mental health issues, and the transition toward palliation. So here, beneficence is going to make that shift from cure into comfort. And the weight of principles then changes with that prognosis. So that'll be echoing the earlier claim that no principle has weight in itself. And then the last case that they use for a paradigm case in the book is Miss Comfort. Miss Comfort is a 58-year-old female. She has metastatic breast cancer. She has a prior lumpectomy and chemotherapy. A pathology of her axillary nodes has revealed disseminated disease. She is in ongoing treatment attempts, but her case faces some of emerging questions about when does treatment become burdensome, when does comfort supersede care or cure, and what counts as a benefit when we can't actually promise the benefit of continued treatment. So miscomfort represents late stage, life-limiting illness. Here, aggressive intervention may conflict with her quality of life. So this case will repeatedly test how we weigh beneficence, non-maleficence, and patient values. It also sets the stage for discussions of futility, proportionality of care, and end-of-life decision-making. So these are our four cases: Miss Comfort, Mr. Cure, Miss Cope, and Mr. Care. So with the evolution of ethical problems in clinical contexts, we begin with the medical indications of the case. Ethical problems typically emerge from things like refusal of treatment, declining prognosis, a changing of goals, and patient values. So looking at paradigm cases allows us to do reasoned comparisons in order to reach more well-reasoned conclusions in whatever case we're dealing with. So that is our introduction to our new textbook. I tried to keep it short and sweet today, and then we'll dig into the nitty-gritty of it next week. If you guys have any questions, the floor is yours. Stop sharing. Or if you want to ask anything about the justice outline that I posted last week, we can go over that as well. If y'all are good and feeling confident, you are free to go. See you Thursday.